Okay, so we are going live now in 3, 2, and 1. We are live.
Good evening and warm welcome to the 58th session of Pediatric Orthopedic Active Learning Session. We started this program before almost 2 years in July 2022, and in 2 years we had 48 sessions. Today is 49th and the 50th session, and on this special occasion, I shall like to thank few people. The first is OrthoTV, Dr. Ashok, Shyam, Neeraj, Bijlani, and the whole team of OrthoTV has made it possible so that thousands of viewers across the globe can learn from this session. OrthoTV provide us with the Zoom meeting platform and also provide the facility to live stream these sessions. On an average, each session is viewed by more than 1,000 people. I just would like to mention one very popular session by Dr. Sheetal Parikh from Cincinnati, which was on patellofemoral instability. And that session is viewed by, I checked yesterday, and it's viewed by more than 6,800 people. So that's the reach of Ortho TV session and this session. So on this occasion, I request Dr. Ashok Shyam to share his views about the session. And again, I would like to thank both Ashok and Neeraj for providing us all the technical facility. Over to you, Ashok.
Thank you very much, sir. And I think it gives me immense satisfaction to create this platform where such programs are showcased. So POALS has been a flagship program since last 2 years. People look forward to this program because of the content that it has. And I think so many international speakers in pediatric orthopedics, I mean, who's and who's of pediatric orthopedics has been on this platform. The conceptualization of polls is completely done by Dhiren sir, and he chooses topics that are trending. That is why it is called active learning. So I think he knows the pulse of what pediatric orthopedic education needs, and based on that, he creates these programs, calls the speaker. He takes so much effort in creating these that, I mean, it has to be successful. Like sir said, thousands of people, thousands of surgeons are viewing this, learning from this, and deploying this knowledge for treating their patients. So it is definitely even impacting patient care all across the globe. So thank you very much, sir, for running this polls program, and I hope we'll have more than 100 episodes very soon. Over to you, sir.
Yeah, thank you, Ashok. Once again, Ortho TV and everyone like for active participation and the full support to this session. I should also like to thank world-renowned pediatric orthopedic surgeons. There are 39 pediatric orthopedic surgeons. They came as a faculty for this program. The few one like Professor Vincent Mosca, Professor Benjamin Joseph, Freeman Miller, or Jason Howard, they have come at least 3 times for these sessions. So we are really thankful to them because the time which they spare for this session is either for their busy practice or from the family time. So once again, I am very thankful to them for sharing their knowledge and vast experience with our fellows. I would also like to thank our own professors like Professor Hitesh Shah from Manipal, Professor Thomas Palokaran from CMC Vellore, Professor Neeraj from Chandigarh, and Dr. Anil Agrawal from New Delhi, who has supported this endeavor wholeheartedly. On this special occasion, we have 2 luminaries of pediatric orthopedic with us. The first speaker is Professor Benjamin Joseph. He will speak on a topic which is very difficult. Very few people have courage to accept their mistakes and to talk about those mistakes with their colleagues. Most of us are smart enough to learn from our own mistake, but the aim of this session is to learn from someone's mistake, and that someone is the great pediatric orthopedic surgeon of India, Professor Benjamin Joseph. After his talk, we will have Professor Vincent Mosca, who will speak on anterior calcaneal osteotomy or lateral column lengthening or the Mosca's procedure. He will reveal minute details of his technique so that we can get the best result. He will also speak about the proper indication, extended indication, surgical technique, and how to avoid complications. And at the end, the limitations of this surgery. I am sure that both these lectures will help us to become a better orthopedic surgeon and also a better human being. With that, I request Professor Benjamin Joseph to share his screen. Over to you, sir. Thank you. Yes, perfect, sir. Yeah, perfect.
You can hear me?
Yes, yeah.
Okay. So I'm going to talk about the mistakes I made and the lessons I learned from each of the mistakes. Now, the examples that I've taken are from my pediatric orthopedic practice. But I would mention that I would be mentioning the lessons that I learned. If you look at them carefully, you realize that this is applicable to situations in real life far distant from pediatric orthopedics. So please pay attention to the lessons that I mentioned. A disclaimer, I will have to state that all the complications illustrated in this talk are mine. You might have listened to many talks where you show a patient who has run into a complication and the speaker says, this patient was operated somewhere else, the so-called saint elsewhere. I take responsibility for each of the complications that I'm going to talk about. The second disclaimer is that I do not claim to have had 100% success with zero complications in any conditions that I have treated. And I feel very uncomfortable when somebody says that their results are 100% good. So what are the mistakes that I have made and what lessons have I learned? Each case will be preceded by a work of art that draws attention to the problem that we're going to talk about. I've been interested in art, particularly so after I retired, and I would like to introduce some art to each of you. Hopefully that you'll continue to look at some of the beautiful works done by people. Next, each case will be followed by lessons that is learned. The lessons are equally applicable to clinical medicine, as it is vital issues. So please think deeply about each of them.
Please take a question.
The first artist that I'm going to talk about is Emil Munier. Now, Emil was involved in painting human subjects. Most of them were his family, his children, his nephews and nieces, his wife. And he painted these beautiful paintings of these subjects. And one of the interesting things is all of them were barefoot in these paintings that he had. And that draws my attention to asymptomatic flat foot in children. In the early years of my orthopedic practice, that is from 1976 to 1986, and 76 was when I started training in orthopedics, I prescribed shoe modifications for asymptomatic flat foot because the parents would say, well, this child has got something funny in the foot, or they knew the term flat foot, and I would promptly provide them with some shoe modification, which was the teaching of the day at that time. In 1986, I had the good fortune of going to Sheffield, and 1987 to go to Alder Hey Children's Hospital. Now, interestingly, both these places had a foot clinic, which was around, if I remember correctly, on a Wednesday. And the vast majority of children who were brought to the clinic were brought there because they had flat foot. I came back to India after these 2 years, and I just noticed that in my clinic, I hardly saw any children with flat foot. And this intrigued me. So I said, is it because flat foot was rare in India? And if so, what was the reason? So I asked one of my postgraduates who was doing a thesis to get footprints of children between the ages of 4 and 14 who, he went to the school. So he actually screened 2,300 children with the help of a Harris and Beath mat. It's a differential pressure mat which shows up where the force is being taken while weight bearing. A large proportion of about half the children actually wore shoes, some form of footwear. We examined these children for ligament laxity because it's a confounding variable. So also the body mass index was calculated to see whether they were obese children. And then we classified the footprints into normal, high arched or flat foot according to the criteria that is laid down here. And what was interesting was the incidence of flat foot was 8.6 in children who used footwear and 2.8 in children who did not use footwear, and this is highly significant. So the question we ask is, does shoe wearing influence the prevalence of flat foot? And the answer is yes. The next question is shoe wearing detrimental for development of the medial longitudinal arch? Now, in order to answer that, we had to remember that the critical age for the development of the longitudinal arch is around 6 years. And a lot of people have shown that you have flat foot in a vast majority of children in toddlers, and by about 6 years, the arch develops. Now, if shoe wearing does contribute to failure of development of the arch, the age at which the shoe wearing begins should influence the frequency of flat foot. Shoe wearing before the age of 6 could predispose to flat foot, whereas if shoe wearing was delayed until the child was older, the propensity to flat foot would be less. This was the hypothesis. So in order to answer that, we took static footprints of adults, 1,846 adults. And all were using some form of footwear at the time of the survey. And all of them were asked, when did you start wearing footwear? And it so happens in rural India, and my institution is actually in rural India, the point at which they might start using footwear was sometimes is when they start going to school, which is around 5 or 6 years of age. So that was a clear point. The second point was when they finished school and started going to college, around 15 or 16 years. So we asked that we analyzed these adults with footprints and looked at the shape of the foot in children who had started using shoes under the age of 6 years, those who started wearing it between 6 and 15 years, and those over 15 years. And again, interestingly, there was a difference. Those who started wearing shoes after the age of 15 had a much lower incidence of flat foot. And again, this was highly significant. We then asked them, do you remember how long you wore the footwear when you were young? And many of them could recall that. Those who said they wore it in less than 8 hours a day had a lower incidence of flat foot than those who wore it for more than 8 hours a day. And again, this was statistically significant. We then asked them, what type of footwear did you wear? And then we found out that those with closed-toe shoes had the highest incidence of flat foot as compared to slippers and sandals. These findings of these two surveys suggested that there was an association between shoe wearing and early childhood and flat foot. The type of footwear, the duration for which they were worn also had a bearing on the prevalence of flat foot. Brings me back to these paintings. All these children have beautiful arches, well formed. Could it be because they played around barefoot? In the light of the results of these surveys, it's certainly not justifiable to continue prescribing shoes and shoe modifications for flat foot. And by 1986 or 87, I stopped prescribing shoes for flat foot. Who says that flat foot is bad? Just look at some of our beautiful elephants. So the lesson that I learned, question existing practices. Strive to change what is not right. And again, I draw your attention to the fact that this applies not just to clinical medicine, but to societal issues. In 1989, Dennis Wenger and his team published an article about the effectiveness of shoe modifications for correcting flat foot. And they showed it didn't make the slightest difference in terms of altering the natural history of the foot or the shape of the foot. The next artist that caught my attention was a young man called Raja, who unfortunately, who was from Tamil Nadu in India. Unfortunately, he died. He succumbed to COVID. He was well known for realism in his oil paintings of subjects from South India. And this is one of his paintings. Stunning, almost like a photograph. And yet another one. Again, these children are barefoot. So these children from rural India go to school without wearing any shoes on their feet. So well-meaning Rotary clubs, Lions clubs, and so those type of clubs said we must help these children, give them footwear to go to school. And promptly, there were people who were willing to do that. But what was the choice of footwear for these rural children? Closed-toe shoes. Fortunately, there were some schools where they were given recycled slippers to use. On the basis of what I told you earlier, which is more appropriate? Clearly, giving them slippers is probably not only healthier for the foot, but probably more comfortable in this humid, hot climate of India. So the lesson you learn from that is question the appropriateness of well-meaning actions and change them if it is needed. Sorolla was a Spanish artist. He was famous for his paintings of beach landscapes. And he made this painting, which is called Sad Inheritance, one of the most famous paintings that he did. And what do you see there? Children with polio being brought to the sea. Here's a child with quadriceps paralysis, a hand-to-knee gait, in another painting of Sorolla. This brings me to the concept of the paralyzed foot. In 1976, when I started my practice, I assisted one of my seniors to treat an adolescent lady with deformities of the feet following polio. The left foot, which is shown here, was in severe varus. The tibialis anterior was grade 5, the peroneal was 0, which accounts for the varus deformity. The right foot, there was hindfoot valgus, but the foot was flail, and so was the ankle. No muscle was functioning at all around the foot and ankle. What was done? On the left side, we did a triple fusion. On the right side, we did a modification of the triple fusion. We did a Landau-Nudipus procedure, again, basically hindfoot stabilization. Both feet, the deformities were pretty well corrected. The feet became plantigrade, and the joints were stabilized. 2007, this lady came back, and surprisingly, she recognized me. I tried to hide under the table, but I couldn't. She recognized me and said, "You did this operation, and the deformity has recurred." The right foot, however, remains perfectly plantigrade. Why is this difference? Clearly because muscle imbalance persists on the left foot, whereas there is no muscle imbalance on the right foot because it was a flail foot. So it becomes evident that in order to prevent a recurrence, the deformity correction should have been combined with restoration of muscle balance, which we did not do. So what is the lesson we learn from here? Identify the underlying cause of a problem and resolve that, lest the problem resurfaces. Apply this to issue when there is no harmony in a society and there's been a riot, for example. Stopping the riot alone is not enough. Finding out the cause of the riot is more important. The next contemporary artist is again an Indian, Shashikant Dotre. He specializes in portraits drawn on pencil and crayons on paper. Again, amazing, remarkable details of the clothes of the subjects. Just look at that. That's a piece of art. And look at the beauty of the details of the sari that's worn by these ladies. reminds me of osteofibrous dysplasia. I encountered a child with proven osteofibrous dysplasia, and the biopsy showed there was adamantinoma-like changes, and therefore that warrants aggressive surgery. So I excised a large segment of the tibia subperiostally, and I did a Huntington's procedure in a single sitting. The fibula was exceedingly thin, and all that I could manage was to pass this thin, measly K-wire across. Despite that, the fibula united with the tibia quite well, and the tibia bag began to get reconstituted within the periosteal sleeve. So far, so good. But as time went on, features of the osteofibrous dysplasia were evident in the tibia that was regenerating from the periosteal tube. And you can see that as time goes on, almost an identical recurrence of the tumor has occurred. We then did an extraperiosteal resection of the diseased tibia, and there was no recurrence after that. So this is one instance where you do need to throw out the wrapping with the contents. The periosteum must go if a recurrence of osteofibrous dysplasia is to be prevented. Now, it so happens that when I did the surgery, there was very little literature about osteofibrous dysplasia, at least what was to be done for it. And therefore, I fell into the trap of doing a subperiosteal excision. The diseased periosteum will lay down diseased bone. I learned that now. And the lesson that we learned was pay attention to what is less obvious. Don't focus on the bone alone, the surroundings. The periosteum needs our scrutiny. I now draw your attention to another famous Indian artist, Raja Ravi Verma. And he drew a beautiful painting of his own wife and child. And what I draw attention to is the way she is holding the child with the hips widely abducted. Clearly advantages for development of the acetabulum. Which brings us to the hip. And I encountered septic arthritis in a neonate. A low birth weight baby in neonatal ICU on IV antibiotic for septicemia. On the 10th day after admission, had diminished movements of the left lower limb. A diagnosis of septic arthritis of the left knee was made. An arthrotomy and a washout were performed on the same day. And unfortunately, the diagnosis of septic arthritis of the hip was missed. However, since the antibiotics that were effective against the bacteria isolated from the knee were administered, it was assumed that there would be no residual problem. Follow-up radiographs of the knee were perfect. The function was excellent. Follow-up radiograph of the hip, unfortunately, is not perfect. Inappropriate decision-making, mine, has resulted in lifelong disability. Since antibiotics that were effective against bacteria isolated from the knee were administered, it was assumed that there'd be no residual problem, and a drainage of the hip was not done. Assumed. Never assume anything in clinical practice, lest it makes an ass of you and me. And I am reminded of my teacher, Professor Chako, who on more than one occasion has written this word on the board, assume, and split it into ass of you and me. There's another French artist who was employed by the King of Spain. I can't pronounce the name very well, so I'm not attempting it. And he specialized in painting court dwarfs. And here is a man who is a dwarf, and beautifully painted. Which brings me to skeletal dysplasia. A 12-year-old girl with a very rare form of spondyloepiphyseal dysplasia congenita had a stunted stature, no gross deformities of the spine, knees, and ankle, but had severe pain in both hips that prevented her from attending school. She walked with a painful Trendelenburg gait. The radiographic appearance of both the hips were identical. That's what it looked like. Extreme coxavara. sort of fragmented epiphysis and a very poorly formed acetabulum. What could be done? If it was in the West, probably you treat it like juvenile idiopathic arthritis and do an arthroplasty. But in our setup, considering the socioeconomic status of the child, we felt this was not a good option. And we did bilateral excision arthroplasties followed by valgus pelvic support osteotomies. Excellent relief of pain, marked improvement of gait. The girl was very happy with the outcome, and so were the parents. So we were delighted. However, there's a disadvantage with this procedure in childhood. The valgus angulation in a child will remodel, and hence the osteotomy may have to be repeated before skeletal maturity. You can see here that the remodeling has begun, quite advanced. But more than that, you can see that newborn is laid over the plate. And to remove the plate, we had to dig into the bone, and that is the outcome. Right? Remove the plate as soon after union is obtained after subtrochanteric valgus osteotomy in children. It's something worth remembering. Lesson: the timing of intervention is vitally important. In many situations, a delay may have disastrous consequences. Josep Ribera painted something which is very, very famous, and most of you might have seen this picture of a child with a deformity of the right foot, and it's titled in French, which means club foot. And many books on clubfoot somehow show this illustration. But to my mind, and to many others who have written about it, it looks very much like a spastic equinovarus rather than idiopathic clubfoot. So we'll talk about spastic equinovarus. Spasticity of inverters. We saw a child in whom we thought that the tibialis posterior was responsible for the dynamic equinovarus. The postoperative situation, we did a tendon transfer. And what we did was a complete transfer of the tibialis posterior to the dorsum of the foot. And this resulted in overcorrection, a calcaneovalgus deformity. And we were then taught avoid complete transfer of tendons because overcorrection can occur. Think in terms of a hemi-transfer, particularly of the inverters. Overdoing any intervention may result in a situation as bad as the original problem. So this is something worth remembering in day-to-day life. Augustus Comte, a French artist, showed a beautiful painting, did a beautiful painting of a boy who was disabled and begging for alms. And he had a bandage around his foot, probably a neuropathic ulcer. This brings us to the concept of an insensate foot. The child had an equinovarus deformity of the foot, which was perfectly well corrected by appropriate surgery. Postoperative guidance regarding the care of the anesthetic foot was ignored. There was poor patient and parent compliance. And the toes have started ulcerating. All stakeholders, the child, the caregivers, and the treating surgeon, need to be actively involved in preventing these complications. Now, clearly the mistake that I made was I had not worked out that this family is not going to comply. I should have assessed this in advance. An artist called Karachi did this sketch of a disabled boy with spinal deformity. It's reminded of a child whom I encountered with non-union of the humerus, atrophic gap non-union of the humerus, and osteogenesis imperfecta. So those are the days when the telescoping rods were first introduced, and I put a Sheffield telescoping rod into the fragment hoping that it will unite. The procedure failed. I then revised it with the telescoping rod again and used autogenous bone graft. This also failed. Then I revised it with another rod, added an external fixator, added maternal cortical bone graft, and applied a shoulder spiker. You can see desperation setting in. These are sequential X-rays. This also failed. We were back to square one. We then shared our experience with these failures in an article. And it so happened that I went for a meeting which was attended by Mike Bell from Sheffield, which is a good center for osteogenesis treatment. And he said he had exactly the same experience with gap non-unions of the humerus, atrophic gap non-union. And in a textbook, which is published a year ago on osteogenesis, this is well documented that operating on these cases with the atrophic non-union is a futile surgical exercise. So some problems are better left alone. And we need to acknowledge our inability to improve the situation, but think of ways of preventing it from occurring in the first instance. It's evident that if you can fix the humeral fractures as soon as they occur, they won't go into a gap non-union. So delay in fixing it is probably what leads to a gap non-union. Second thing that you learn from this, even the exceedingly weak bone of osteogenesis can totally wreck your ego. So it brings me to the term complications. I've learned a great deal from my own complications by admitting them, analyzing them, sharing them with others. And I'm sure that this approach will help you too in your practice. Don't hide it, admit them. It needs to be acknowledged that the vast majority of complications can either be predicted and many can be prevented. In other words, if a preventable complication arises, it's because we made a mistake. Take an example of compartment syndrome. If you cannot detect an impending compartment syndrome or the early stage of a compartment syndrome and let it go on to a full-blown compartment syndrome, it is your failure. And if you analyze why complications occur, it's because one did too little, did too much, did something which is correct, but it was too late. Or we've chosen the wrong operation, the wrong patient, the wrong decision to operate. The wrong patient, I'm not meaning that you mixed up the case files and done the wrong operation. The example is that child who with insensate foot, it's probably a wrong choice of patient. So too little. Here's an example, which I showed you. Too much, overdoing of a transfer. Too late, which should have taken the implant out a long time ago. A wrong operation, should have done a split transfer rather than a complete transfer. The wrong choice of patient, you should have known that the patients are not compliant, or at least educate them into becoming more compliant. And the wrong decision to operate because it's a futile attempt. Now, is it possible to take a vote on this? Can the participants let us know what they feel about this? Can I ask one question? Dhiren, how does that work? Is it possible?
Sure, sir. We will answer in the chat.
Okay. Here are footprints of a child who is walking. And how many of you would agree with what seems obvious, that the child is walking in this direction? Yes or no? Are there any no's? Are there many yes?
Yeah.
Are there many yeses?
let's see, like, please, everyone to ask, write down their answer. So let's see the chat. Yeah, yes, 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 yes. Yeah, so everyone is saying yes.
Okay. So in other words, no one is supporting that the child is walking in this direction. Okay. So the majority opinion is that the child is walking in this direction. Okay. Fair enough. But look at the child. Look at the shoes of the child. Now do you think that the child is, which way is the child walking? Because the shoes are worn back to front, the footprints will look as though the child is walking in one direction when in reality the child is walking in the opposite direction. The feet are deformed in that fashion. The toes are pointing backwards and they put it into a shoe and they walk with the heel of the shoe pointing forwards. So we need to bare the feet to know if the footprints reflect the direction of progress. And the lesson we learn is do not presume that all is well until the hidden truth is revealed. And even more important, do not hesitate to challenge with an appropriate evidence the majority opinion. Here, the majority opinion was that the child is walking in one direction when it was the opposite. And we have proved it by looking at the child taking off the shoe. So in any situation in life, do not hesitate to challenge with appropriate evidence that if the majority opinion, which is biased or blatantly incorrect, you must challenge. This is a beautiful sketch by a famous artist called Goya, who at 80 was sketched this and said, I am still learning. I too am still learning. Thank you very much.
Yeah, thank you very much, Professor Benjamin Joseph. And I'm sure that each point which you mentioned in this lecture has a lot of wisdom in it. And I'm sure that a lot of pediatric orthopedic surgeons attending this meeting and also viewing this program on live streaming will learn a lot from it. And definitely our thinking will be more widened and we will think very literally also. So I would just request Professor Mosca to comment on this lecture.
Yes, I'm happy to do so. Benjamin, I've known you for, I think, decades, and I have mostly known you socially. I've read your prolific publications, and I've learned so much from them. Hearing you give this lecture shows knowledge, experience, confidence, and the appropriate message for the trainees, which is that none of us is perfect. Curiosity helps us get better at what we do, and being honest helps us make the decision that perhaps what we were doing was not as good as something else might be. So thinking back to how Dhiren Ganjwala convinced me to give a talk last week that I knew nothing about, I think your talk really ties into the whole concept that we are or are training to be orthopedic surgeons, pediatric orthopedic surgeons. It's not easy. And I've said this many times, if what we do was easy, anybody would do it, and they don't. We do. For us to be as good as we possibly can for society, for the patients who come to us for care, we have to continue to question what we do. We have to be honest with what we see, and we need to admit mistakes, rejoice in the good decisions, and move on. And it never ends. Throughout one's entire career and afterwards, it's still appropriate to reflect on one's career. I was wondering, so wonderful talk. I was wondering, have you written down, these remind me of the principles that were the foundation for me writing my book on foot deformities, because it's not really about the techniques. You showed techniques and you showed how either they weren't indicated or they were the right answer at the time. So even though I call mine principles and you call yours lessons, have you written these down any place to make them available to others? Because I think they're just absolutely inspirational and foundational to be the best pediatric orthopedic surgeon that one can be. So have you written these down?
I haven't put it down in print anyway. I probably should.
Because I would love to share it, even though I'm retired a couple of years, I'm still in contact with the trainees in my program, and I would love to share it with them. I sometimes Zoom into the weekly meetings, and I think the lessons are just so profound and so brilliant that I, for one, would love to share them.
You're welcome to use the slides.
Okay.
Or else what we can do is like, I will share you the live streaming link. So this lecture will be on a YouTube. And
Okay.
anyone can view this later. So that's possible. So I will share that YouTube link with you.
Great.
Thank you,
Thank
David.
you.
Yeah. I'm sure that this being an oration, we don't allow any questions. But Professor, would you like to take one or two questions?
Oh, sure. No problem.
Yeah, Thomas, would you like to ask some tricky question to sir?
No, I was just wondering about the bilateral pelvic support osteotomy, sir. Do you do bilateral at the same sitting, or doing bilateral, is there a problem with the child walking or going through a door, for example? Or I know
I can't recall whether it is done simultaneously, but I think it was.
It was.
And once we put the plate, we don't put any, abduction casts or anything, so that's not a problem.
Brilliant lecture, sir.
Thank you.
Learned a lot.
Thank you.
Yeah. So thank you very much, sir. This is a very special session, and on that you really gave a excellent message. And I'm sure that every pediatric orthopedic surgeon of India and outside also are going to learn a lot of things and will probably help them to reduce the complications in their practice. So that's really great of you, and thank you once again.
Welcome. Thank you.
Yeah. So with that, we move on to the second talk of the today's session, and that is Professor Mosca's speaking on his own Mosca's procedure. And I'm sure that we all do that, but we are going to learn something new from this lecture. So over to you, Professor Mosca.
Okay, let me see if I can do this appropriately. I'm going to make that smaller, and I'm going to bring up. Where did it go? Put it back down there. And what I really want is, hold on just one sec. I had these in my right lower corner. I'm going to pull up. Here we go. Can you see that?
Not yet.
Okay. Oh, I see. Go back to Zoom.
Yes. Yes. Yeah.
Okay, fantastic.
Perfect.
Okay. So let me, again, I'm glad you asked me to comment, Darren, on Benjamin's talk, because he restated so clearly that the most important part of being a surgeon is not performing the surgery. The most important part is having incredibly vast knowledge and being able to convert that knowledge into incredible, wonderful, perfect decision making. And only after using all your knowledge and making great decisions, does it come down to performing the operation? And I would rate the importance is more in the knowledge and decision making than in the technical execution of the operations. I've spoken, I think this is my third or fourth talk in the series, and I hope that I've said each time that the decision is more important than the incision, and that to be an average technical surgeon, which in the world should mean great, but just to be an average technical surgeon, but to be an incredibly intelligent decision maker, it's the decisions and the knowledge that far surpass everything. In May, I gave a talk on the adolescent flat foot, and Dr. Ganjwala asked me to stop short of going through the techniques of the operation. And so I spent really, it was nearly an hour talking about what is a flat foot, what's its natural history, what are the non-operative approaches to those that might cause pain, everything stopping short of the surgery. The request for today was for me to talk about a procedure. So I just don't want anybody to go away thinking that, oh, good, now he's going to finally start to talk about what I really enjoy, which is performing technical surgery. Because what really matters, and I'm going to repeat it, and Dr. Joseph said it again so clearly, flat foot is normal. So I'll go through these quickly because I went over these before, but I can never talk about flat foot without reiterating that most of them should be left alone. So Harrison Beath told us about a quarter of adolescents and adults have flat feet. Most of those flat feet are normal. They're a different than average shape, but just having a flat foot doesn't necessarily cause pain or disability in an individual's lifetime. And about a quarter of flat-footed adolescents and adults have that same flexibility of the foot, but a short, tight tendon Achilles. It's the short, tight tendon Achilles that often, or perhaps always, leads to the pain that some flat-footed individuals manifest. Without the short, tight tendon Achilles, a flat foot rarely causes significant pain or disability. And a small percentage of those 1/4 of flat-footed adolescents and adults have rigid flat feet. Most of them have tarsal coalitions, and even among them, most do not have pain or disability. So whether it's a flexible flat foot or a rigid flat foot, in almost all cases, it's just a different foot shape. And based on these studies and Dr. Joseph's study too, we know that there are many flat-footed babies. There are less flat-footed adolescents and adults. Defining what the percentages of adolescents and adults with flat foot is based on your indication of what does flat mean. When does a short individual go from short to too short or very, very short? It's an arbitrary line, but we know that the arch is lower in babies and higher in adolescents and adults, with some still being considered excessively flat. Not necessarily that that's a problem, but just based on shape, some are flatter than others. And again, Dr. Joseph mentioned, even if you thought, I know this, I want my grandchild, or I want my child to have arches, putting things in and on the shoes do not do that. And based on Dr. Joseph's research, actually putting the shoes on maintains flat-footedness more than not wearing shoes. But there's this group, a small group. It's about a quarter of flat-footed adolescents and adults who have pain in their flat feet. And in those situations where you find an adolescent or adult who has a painful flat foot, not just occasionally, but day after day with regular activities, you find that this flexible flat foot is associated with a short tendon Achilles. Whereas those without the short or tight tendon Achilles, pain is unusual. But in this group, the 1/4 of the 1/4, the pain, tenderness, and callus formation is often manifest right under the fallen arch. And you can see callus formation sometimes redness, or even blistering, depending on how much the individual pushes themselves and is active and what they're walking on. So if the problem is not the flat-footedness, but the short tendon Achilles, one can try to stretch the tendon Achilles and then convert painful flat foot with short tendon Achilles to painless flat foot with normal length tendon Achilles. It's hard to do that. You need to understand the biomechanics of inverting the subtalar joint, straightening the knee, dorsiflexing the ankle. And by inverting the subtalar joint, we're not stretching the subtalar joint into dorsiflexion, but the ankle into dorsiflexion should be tried. If it's not successful to stretch the tendon Achilles, some would recommend an orthosis. But we know that the tight tendon Achilles prevents the ankle from dorsiflexing. The subtalar joint everts and dorsiflexes through the subtalar joint as a part of eversion. And that means that if you put a firm arch support under the midfoot, all you're doing is not stretching the tendon Achilles, not dorsiflexing the ankle. You're just putting more pressure under the unyielding plantar flex talus. So the firm arch support in these individuals, the 1/4 of 1/4 with flat feet, and causing more pain. So orthoses are not appropriate. What does that leave? If the stretching doesn't work, orthoses are not appropriate and increase the pain, then surgery. So I've been giving this lecture for almost 40 years. It may be 40 years ago, I didn't know much about it when I was starting my practice, but within about 10 years, I think I really felt that I understood flat foot. And so all the slides I just gave are just modifications, new colors, new fonts of things I've been talking about for decades. In 2011, there was a Cochrane review on flexible flat feet in children. So for those of you in training who perhaps don't know what a Cochrane review is, a Cochrane review is a group of scientists, deep thinkers in all career fields, but they're scientists. And they pick topics and they search the literature. So they're doing a meta-analysis, but not by people in the field. These are by scientists. So they even have less bias than if you or I were to do a meta-analysis of the same topic. And in 2011, they reviewed the world's literature, and I believe in other languages than English. They scour the literature, and they came up with these conclusions based on a meta-analysis of pediatric flat foot. One, there are more flat-footed children than adults. Just said that. Pediatric flexible flat foot reduces with age. We showed that. And Dr. Staley's footprint study and lateral standing X-ray studies confirm that. Most affected children and adolescents with flat foot are not symptomatic. There's very little evidence for the efficacy of non-surgical intervention to affect the shape of the foot. So you can't change the shape of the foot with doing things into or around the foot, or to influence potential long-term disability. Again, just confirming what said without me doing a meta-analysis. Many low-cost generic foot orthoses can provide good positional support and relieve symptoms, but without changing the structure of the foot. So if a child, for example, has marked laxity and just aching because the joints are loose, the feet are flat, everything's loose, putting an orthosis in isn't going to change the shape of the foot, but it might help the child feel better until they get stronger, older, and their ligaments tighten up a little bit. In the Cochrane review, they also found there's no evidence that supports the use of surgical correction of the typically not symptomatic and flexible pediatric flat foot. Surgery is only indicated if there are symptoms that are not relieved non-operatively, like the ligamentously lax child who just has aching because they're so loose-jointed and not very strong at that age. And they even mentioned arthroresis, which is extra-articular implants that are put in the sinus tarsi to change the shape of the foot. And I talked about this in the past, it was last week when I spoke about it, or at least in May, saying that these implants are not proven to be effective. We don't know their indications. So they, even in the meta-analysis in 2011, found no support for arthroresis, the sinus tarsi implants back then. So if surgery is going to be performed for that small group, we have 25% of adolescents and adults who have flat feet with tight tendon Achilles, many of whom will have pain, and we can't stop the pain with stretching the tendon Achilles. It's not appropriate to use orthoses, then go to surgery. So what's the surgery? Over the decades, the procedures described for flat foot, and I have to acknowledge that in these articles, especially from decades ago, there were surgical techniques proposed to correct flat feet, but it wasn't clear in almost any of them what the indications for surgery was. Was it pain? Were they operating because of appearance? Were they operating because of, don't know why they were operating, but these procedures were recommended for flat foot. Again, we don't know the indications. Soft tissue releases laterally don't work. Biomechanically, as I said in one of my previous lectures, if you have a flat foot, then you would think if you have a cable varus foot or a club foot, releasing medially starts deformity correction. But if you have a flat foot, releasing the soft tissues laterally doesn't do anything because of the arrangement of the bones and other factors. But so lateral releases don't work to correct flat foot, and medial plications, tightening of the plantar medial soft tissues, doesn't work. In the operating room, if you tighten the tib post and you plicate the talonavicular joint, the foot will look like it has an arch. And as soon as the postoperative cast comes off, the soft tissue stretch out. So these procedures don't work. What about tendon transfers? Can you take the tendons on the lateral side, put them medially and correct a flat foot? Well, one of the principles I've talked about in the past and have written about extensively is that tendon transfers, muscle balancing, does not correct structural deformities. No more so than do structural deformity correction balance muscles. They're two independent, some related, but they're independent. So transferring tendons is not going to correct the flat foot. Removing bones has been recommended. I can't even imagine how anybody would remove any bone in the foot from an otherwise normal child with a flexible flat foot. It doesn't make sense. We're not talking about arthrogrypotic feet or myelomeningocele feet, idiopathic flexible flat foot. No one would remove a bone, but it's been recommended. Arthroresis, the interposition of bone or synthetic materials into the sinus tarsi to correct foot shape, recommended high complication rate, at least 30% risk rate of complications, many of which are either creating pain that wasn't there in the first place or creating intractable pain that doesn't resolve even after removing the implants. What else has been proposed to correct flat feet? Arthrodeses. The subtalar joint is the shock absorber of the foot. It's the shock absorber of the body. And arthrodesis, particularly the subtalar joint, just cannot be recommended because of the terrible complications resulting in stress transfer to the ankle, to the knee, to the body. So the only thing that's left, if surgery is necessary for the intractably painful, flexible flat foot with tight tendon Achilles, are osteotomies combined with other procedures. Decades ago, the posterior calcaneus medial displacement osteotomy was considered either the operation of choice or a component of the operation of choice to correct painful flat feet. The acetabulum pedis, the cup within the foot in which sits the head of the talus, so it's the acetabulum of the foot, not the acetabulum of the hip. If one performs a posterior calcaneus osteotomy, it's what I consider the Chiari osteotomy of the foot. It doesn't address the malalignment at the talonavicular joint. It creates a deformity to make the foot look better. Just like a Chiari osteotomy at the hip doesn't really reduce the femoral head into the true acetabulum. It creates a deformity. So it looks like the deformity was corrected, but it actually is a compensation. You can see there on the left is a normal neutral aligned heel. In the center is a valgus hindfoot. And the posterior calcaneus displacement osteotomy shifts the tuber of the calcaneus medially so that when you look at the individual from behind, the valgus is no longer there. But because of the biomechanics of the foot, cutting posterior to the interosseous ligament, cutting the tuber of the calcaneus does absolutely nothing, zero, to correct the malalignment at the talonavicular joint, which is where the pathology is, where the symptoms are. It's the talonavicular joint, the anterior part of the subtalar joint complex that needs to be aligned, and the posterior calcaneus osteotomy does nothing to that at all. All it does is make the foot look better when you see the individual from behind. So in 1975, Dilman Evans from Cardiff, Wales in the UK proposed an operation to correct what he called calcaneal valgus, which we would say called flat foot deformity. He came upon this because his 1969 article presented a way to treat residual club feet, either residual club feet, recurrent club feet, neglected club feet. And he said that in those foot deformities, the club foot, there's a short medial column and the lateral column or border of the foot is relatively long. So to correct those foot deformities, the older child, or adolescent perhaps, would be to perform a medial soft tissue release to initiate eversion of the inverted subtalar joint, but that often wasn't enough in these older, stiffer feet. And that after the plantar medial release, one should shorten the long lateral column relative to the short medial column by a calcaneal cuboid joint fusion. In some feet, he overdid it. He took too much bone out of the calcaneal cuboid joint when fusing it, and he created flat feet. In others, he performed the calcaneal cuboid fusion in young children under age about 8. And although their feet looked great initially, over time, the feet grew into a flat shape. That was 1969. He then thought, well, if a cavovarus residual clubfoot has a short medial column, a flat foot has a short lateral column, some that he created. And he just said, so the way to treat flat foot or calcaneal valgus is to lengthen the lateral column. He decided he would leave the calcaneal cuboid joint alone because he wasn't really pleased with how things turned out. So he thought in the flat foot, to lengthen the lateral column, to reshape the foot, should be done through the anterior calcaneus. But that was in 1975. And in 1995, I published my interpretation of what I thought his concept was, because he presented a concept, not a technique. And as I mentioned last week, I thought the concept was brilliant and couldn't understand why 10 years later, when I started performing the operation, trying to figure out why the concept didn't seem to catch on, I learned a lot by being inquisitive, by being curious, and developed a technique based on Evans' concept. And the concept was that if you lengthen the lateral column through the anterior calcaneus, you can correct all components of even severe valgus eversion deformity of the hindfoot at the site of deformity, not creating a Chiari compensating procedure, but correct the deformity at the site of deformity, where you can align the talonavicular joint that's out of alignment, also correct the hindfoot valgus, but the hindfoot valgus is much less important than aligning that malaligned talonavicular joint. And I found that in my series, symptoms were relieved, the pain. The subtalar joint complex function was restored. There was no arthrodesis involved. We kept the joints moving, a very important principle, and calcaneal growth continued. Phillips from Cardiff, Wales, reported on a large series of Evans patients in 1983. Remember, the Evans paper was 75. Phillips at 83 reported a 13-year follow-up on Evans patients and found that the feet were comfortable and functional. Back in 1983, the journals didn't require too much more information. They didn't need patient-reported outcomes, radiographs weren't full, but they reported the best 13-year follow-up on any procedure for flat foot, which encouraged me to try to figure out what Evans was doing or what they were all doing in Cardiff, Wales, but hadn't reported on. There was no other information about it. The anterior calcaneal osteotomy is like the Salter osteotomy, not the Chiari, but the Salter osteotomy of the acetabulum pedis. The flat foot has a low center edge angle, just like the hip above. There's a low center edge angle of Viberg in the acetabulum pedis or in the acetabulum. And the calcaneal lengthening osteotomy, like the Salter, is a redirectional osteotomy, not only in the frontal plane, but three-dimensionally. The Salter brings the acetabulum lateral and anterior. It rotates. So you can't see that in an AP X-ray, but that's what's happening. Likewise, in the foot, the calcaneal lengthening osteotomy corrects we'll call it pseudo acetabular dysplasia, low center edge angle of Viberg of the foot, in this plane by rotating inward, but the subtalar joint also rotates downward. It's a down and in. The everted subtalar joint up and out with a low center edge angle becomes down and in inversion, plantar flexion, internal rotation, corrects the acetabular dysplasia in the frontal plane. So it took me 2 years to get my article published in the Journal of Bone and Joint Surgery because the editor-in-chief, it went through the reviewers who wanted to accept it with revisions. The editor-in-chief was brilliant. Henry Cowell could not understand why the calcaneal lengthening osteotomy didn't correct flat foot deformity. I said in my title of my manuscript that it corrects valgus eversion deformity of the hindfoot, not that it corrects flat foot. They're not the same thing. A flat foot has many parts to it, and the calcaneal lengthening osteotomy corrects the subtalar joint malalignment. It took months and months, almost 2 years of back and forth. And at the time, we didn't have emails. It was all written either by hand or typed. It was a painful procedure. And after at least a year and a half, he finally wrote back and said, I understand it. It's not an operation to correct flat foot. It's an operation to correct valgus eversion deformity of the hindfoot. And a flat foot, those 8 letters, actually represent multiple deformities. So you have to do other things. But if you want subtalar joint eversion to be corrected, this is the way to go. In the 27% of 23% of adolescents and adults who have flat foot, they also have a tight tendo Achilles. What are the deformities in the symptomatic flat foot? Valgus eversion of the hindfoot. I'm talking about that. But what makes them painful is the contracture of either the gastrocnemius or the entire triceps suri. That's why they're symptomatic. And because you all understand now about if the hindfoot is in valgus, for all the metatarsals to be on the ground, there has to be supination deformity within the calcaneal pedal unit, the CPU. All the bones of the foot except for the talus, there's supination. These are the deformities. They always have valgus eversion of the hindfoot, the flexible flat feet. With tight tendo Achilles, they have a tight tendo Achilles, or at least a gastrocnemius. They all have supination of the forefoot. But my experience has been in the younger children, the forefoot supination, which truly exists, appears to correct spontaneously when the hindfoot deformity is corrected with the calcaneal lengthening osteotomy. In the older children, the young to later adolescents, the forefoot supination within the calcaneal pedal unit is rigid. It's a third deformity and needs to be addressed. So between my seminal article in 1995, I've written up my interpretation and development of a technique based on Dilwyn Evans' concept. And there are many ways to find it, including the second edition of my book that should be out next month. Why is it important to stress that when people say they're doing the Evans procedure, they're not? And the importance is that this is a direct quote. Everything you see on this slide is all that he wrote about the technique. his technique, his brilliant concept. Incision is made over the lateral surface of the calcaneus, parallel with and just above the peroneal tendons, avoiding the sural nerve lest it be involved in the scar. The anterior half of the bone is exposed, the anterior part of the calcaneus, and the calcaneal cuboid joint is identified. The anterior end of the calcaneus is divided through its narrow part in front of the peroneal tubercle by an osteotome, the line of division being parallel with and about 1.5 centimeters behind or proximal to the calcaneal cuboid joint. The cut surfaces of the calcaneus are then prized apart by means of a spreader, and a graft of cortical bone taken from the tibia is inserted between the blades of the spreader to maintain separation of the two pieces of the calcaneus. That's it. Period. Done. That's it. That's all he wrote. And from 1975 until about 1995, maybe a few years earlier, because people had heard me at meetings talking about my modification of his technique and concept, nobody was doing it. Because these are the things that I discovered through curiosity, through inquisitiveness, through experimentation. These are the things that are necessary to bring his brilliant concept into common use for safe and effective management of painful flat feet in children and adolescents. And they're all important. Again, nobody was doing it for 20 years. And then when you actually think about all the parts of it and you develop approaches to prevent complications or to make the concept safe and effective, then it's done ubiquitously as it is now all over the world. The first thing that I came up to is, what are the indications for flat foot surgery? As I said, I read all the literature and I wasn't sure why the procedures were being done in many of the reported series. Indications: severe valgus, eversion deformity of the hindfoot. Yeah, but with a failure of non-operative attempts to relieve pain, callus formation, either under the head of the talus and or in the sinus tarsi. So now we're going to go into technique, and I don't usually talk about techniques during lectures because I think that everything I've said so far today, what I've said in my previous lectures about that you shouldn't operate on flat feet in most cases, that flat feet are normal. Everything I just talked about, I try to stress that and say, but if you need to do surgery, these are the things you should do. And I've written it in enough places, you can see in my bibliography, that you can find it. But I'm going to go through them anyway and stress the important features. That was my task. The first thing is that Evans recommended a longitudinal incision. Is my arrow showing? Can you see my arrow
Yes,
on the?
yes.
Okay, good. So Evans recommended a longitudinal incision laterally, which is not very extensile, nor is it cosmetic. There are Langer's skin crease lines in the sinus tarsi, and the modified Ollier incision can go through within one of those Langer's lines. It's very cosmetic, and it's actually more extensile. You can get more places than the longitudinal incision that Evans recommended. You can avoid the superficial peroneal nerve, you can avoid the sural nerve, and make this halfway between the beak of the calcaneus and the lateral malleolus. So the first thing is better incision, more cosmetic, more extensile. In a valgus everted foot, the soft tissues are in the concavity. On the medial side, the soft tissues are on the convexity. So on the medial side of the foot, the soft tissues are elongated. On the lateral side of the foot, where we're entering to perform the osteotomy, the soft tissues are short and contracted. They include the peroneus brevis, the peroneus longus, and what nobody had ever thought about was the abductor digiti minimi, which has a very tight fascial sheath around it. So if we're going to lengthen the bone column, we need to consider what's happening with the soft tissues laterally. In this image from fluoroscopy, you can see the calcaneus. You can see a wire that goes across the calcaneal cuboid joint, but I want to bring your attention to these made-up lines and circles. The abductor digiti minimi, the abductor of the little toe, connects with a tight fascia to the plantar lateral border of the calcaneus, midfoot, going all the way out to the little toe. So the ADM, abductor digiti minimi, is a soft tissue constraint plantar lateral to the calcaneus. The peroneus brevis starts up in the leg, passes behind the lateral malleolus, and inserts at the base of the fifth metatarsal. If we look at this in cross-section, and this is just a schematized cross-section, you see the calcaneus, and lateral to plantar lateral to the calcaneus in cross-section is the peroneus brevis. And more plantar, but still lateral than the peroneus brevis is the abductor digiti minimi. So again, the big picture is a lateral view. This is cross-sectional. And those soft tissues that are tight, they're in the concavity, by definition, are shorter than normal. The peroneus brevis and the abductor digiti minimi are plantar lateral to the calcaneus. So when one cuts the calcaneus and attempts to distract it, there's a tether, there's a tension band plantar lateral that tends to prevent the lower part of the osteotomy from distracting, whereas the dorsal and dorsal medial part of the osteotomy distracts. It creates a jackknife. Posterolateral tether, the calcaneus doesn't just lengthen, it lengthens a little bit plantar laterally, but mostly dorsal medially. That also creates a tendency for the anterior fragment to dorsally subluxate because of this tension band plantar laterally. It doesn't work. In eversion, the subtalar joint, the acetabulum pedis, is dorsiflexed and externally rotated. That's eversion, up and out. When we invert, the anterior calcaneus and the entire acetabulum pedis should go from up and out to down and in. If those soft tissues are not released, the anterior calcaneus and the acetabulum pedis doesn't go down and in, it's forced up. That's why the deformity can't correct well, because of these tight lateral soft tissues. Evidence didn't mention it, but all you have to do is try to lengthen the calcaneal fragments after the osteotomy without releasing them, and you see that the anterior fragment does not want to go down and in where it's supposed to, it goes up. So the answer to that is, if they're contracted, lengthen them. Z-lengthen the peroneus brevis. Release the abductor digiti minimi aponeurosis, both transversely, but also releasing it longitudinally from the edge or border of the calcaneus. Why not lengthen the peroneus longus? Well, we know that the peroneus longus bypasses the lateral border of the foot, goes under the foot, and attaches to the base of the first metatarsal and the medial cuneiform. It is the pronator of the forefoot. And in flat foot, the forefoot is supinated. So if we lengthen the peroneus longus, we're going to contribute to maintenance of forefoot supination. But we know that we want the supinated forefoot to pronate. If we just retract it while we're doing the operation, but don't lengthen it, if you lengthen the lateral column, you push the first metatarsal and the insertion of the peroneus longus away from its origin in the leg, you effectively shorten the peroneus longus when you lengthen the lateral column. And since the peroneus longus is a pronator of the forefoot, by not lengthening it, but just lengthening the bony column laterally, you've effectively shortened the peroneus longus, which pronates the forefoot. In order to expose the calcaneus to cut the bone, you need to elevate the soft tissues from the sinus tarsi. There's also some added benefit by elevating the soft tissue contents of the sinus tarsi to stop any lateral soft tissue tethers and enable the acetabulum pedis to move where it is. So lengthen the brevis, release the abductor digiti minimi, just retract the peroneus longus. You want it to pronate the forefoot, don't lengthen it, and then elevate the soft tissue content. So these management of the soft tissues on the lateral side are going to improve deformity correction. They're going to, and they just make sense biomechanically. A bone column, a soft tissue column. If you're going to lengthen the bone column, you don't want the soft tissue column to prevent the lengthening of the bone column. So what else can we do that is going to ensure success and to prevent complications? The location of the osteotomy. Most people have an anterior facet and a middle facet. Studies have shown, cadaver studies, that many people have a combined anterior and middle facets. Every time I've tried to find it with a joker or freer elevator, I've always found an interval, but we know from studies that sometimes they're combined. The point is that we want to try to cut in the anterior part of the calcaneus. We can insert a freer elevator after we've elevated the soft tissues, insert it perpendicular at the side of the foot. If we go perpendicular, we'll hit the middle facet. We can then rotate the instrument externally and drop into an interval between the anterior and middle facets. But Evans didn't say that. Again, he said 1.5 centimeters proximal to and parallel with the calcaneocuboid joint. And when I've looked at skeleton bones, plastic bone models, pictures in books, 1.5 centimeters proximal to and parallel with the calcaneocuboid joint makes the osteotomy end in the middle facet. We stand on the middle and posterior facets of the subtalar joint. The anterior facet is plantar lateral in an average-shaped foot, and in a flat foot, the anterior facet is on the side of it's lateral to the head of the talus. We don't stand on the anterior facet. We stand on the middle and posterior facet. So these are the important ones. And cutting through the middle facet is an intra-articular osteotomy at the bottom of our body weight. It doesn't make any sense to do that. So I recommended starting laterally a little bit more posterior, a little bit more proximal, have a bigger lateral surface of the bone to work with, and angling medial and distal between the two facets, the anterior and middle facet. That way we say extra-articular. We don't violate the very important articular surface area of the middle facet and have an osteotomy here. So you can put a Steinman pin in, start laterally. You have a long lateral fragment to manipulate, not a short little piece, but a long lateral column, but angling distal medial, aim right for that interval between the anterior facet and the middle facet. Make it extra-articular. Here you can see I view in with this black line the outlines of the anterior facet, the middle facet, and this is the interval that we're going to go for with the osteotomy. Evan said to make it parallel with, ending through the middle facet, but if we start a little bit more proximal, angle a little bit distal, use mini fluoroscopy, we could find that sweet spot between the anterior and middle facets and stay extra-articular. So I showed in the previous film when I was talking about the soft tissue constraints, a wire across the calcaneocuboid joint. This is a very critical step in success of the lateral column lengthening procedure. Even releasing the peroneus brevis and the abductor digiti minimi, the skin, the fat are going to be more minor plantar lateral constraints to distraction of the fragments. So what can we do to not only prevent the acetabulum from correcting, but we need to make sure that there's no instability at the calcaneocuboid joint. In many feet, when we perform the osteotomy and distract the osteotomy, the anterior calcaneal fragment subluxates dorsally. It moves up. It separates at the calcaneocuboid joint. So it prevents deformity correction, but it can also create incongruity at the CC joint that leads to painful arthritis. So my recommendation is to prevent that from happening by pinning the joint in a neutral position, prevent it from subluxating. Then combining the pinned calcaneocuboid joint with release of the plantar lateral soft tissues will ensure that when the osteotomy is distracted, the entire acetabulum pedis goes from up and out to down and in. No subluxation at the calcaneocuboid joint and no resistance to deformity correction because joint is pinned and the soft tissues have been lengthened. Then a laminar spreader can be placed, noting that it's not a triangle that's put in, it's a trapezoid. The deformity, the center of deformity, the foot chora, the center of rotational angulation deformity is in the talus, but we're operating on the calcaneus. I showed this briefly in a previous talk that if you draw out all the lines and you draw the axes of the bones, the deformity is in the talus, but we're correcting the deformity, not operating at the chora, but in the adjacent bone. This is very different from the principles of deformity correction in the long bones. Here you can see in the upper left, the white lines show the talus first metatarsal angle. Abducted, the foot core is in the head of the talus. That is a radiographic definition of flat foot. The purple represents a wire that's been placed retrograde across the center of the calcaneocuboid joint to prevent it from subluxating. And the dashed black line is the site of the osteotomy. The other wires are joysticks. Then if you look in the center at L, the joysticks have been opened up, laminar spreaders in place, there's no subluxation at the calcaneocuboid joint, and by lengthening the lateral column, the navicular moves around medially. In this plane, it's also moving plantarward to correct the up and out eversion to down and in inversion. And if we look here, then lower left in M, now the talus first metatarsal angle has straightened out to within 10 degrees. That's normal, straight foot, no longer everted. The graft is being inserted, no subluxation at the calcaneocuboid joint, and after the graft is impacted the rest of the way, the deformity is fully corrected, and then the wire is advanced through the graft into the posterior calcaneal fragment. Not because the graft necessarily needs it. The osteotomy doesn't necessarily need it. If a cortical cancellous bone graft is inserted properly, it is inherently stable. It doesn't need further fixation either for the graft or for the osteotomy. The only reason that I recommend inserting the wire through the graft and into the posterior fragment is because it's already there. But the reason for the wire is to prevent calcaneocuboid joint subluxation. That's the only reason. And then it's in place, you add it deeper. And you can see the up and out eversion in N. Wires are spread apart, laminar spreader, down and in inversion. When the subtalar joint eversion is corrected from up and out to down and in, the plantar medial soft tissues are redundant. In the flat foot position, the tibialis posterior is extra long. It starts up in the calf, goes behind the medial malleolus, under the head of the talus, and attaches to the navicular cuneiforms. It has many insertions. But in the flat foot, it's longer than normal. And when the subtalar joint is inverted to neutral, the insertion on the navicular is brought closer to the origin in the leg. So basically, the tendon is effectively lengthened. The musculotendinous unit of the tib post is lengthened by correcting the hindfoot deformity. That means that the muscle cannot generate power right away until sarcomeres are lost, the actin and myosin reset themselves. It takes time for a shortened muscle tendon unit to be able to regain power. So my thought was, why don't we Z shorten, not Z lengthen, but Z shorten the posterior tibial musculotendinous unit. Then we don't have to lose sarcomeres. We don't have to reset the actin and myosin. By shortening the unit and getting the muscle at its normal tension, it can start working as soon as the postoperative cast comes off. So instead of doing, you can see a Z marked on the tendon, but it's not going to be a Z lengthening. It's going to be a Z shortening with a Pulver Taft weave. The other thing that happens when we invert the subtalar joint is this very thick, very elongated plantar medial talonavicular joint capsule becomes redundant. It's thick because the individual's been walking on it for years. It's thick. It's not just the normal thickness tenonavicular joint capsule. So when we bring the foot to inversion, there's going to be a redundant capsule that can be resected. And then instead of overlapping the thick capsule for repair, we could just bring it side to side and don't replace the bump of the head of the talus with the bump of the excessive collagen. Here you can see in the lower part that wedge has been removed. There's the head of the talus with pretty collagen. And after the calcaneal lengthening osteotomy has brought the foot into this position, then we could bring the capsule together with sutures front to back and not overlapping. And we can do a Pulver-Taft weave, taking the thin half of the tendon through a slit in the other tendon and having nice repair, resetting the tension on the musculotendinous unit as a shortened overall unit. And by doing it as a Pulver-Taft weave rather than tendon next to tendon, it's less collagen. Remember, in the flat foot, there's a bump. The bump is the head of the talus. When we correct the flat foot deformity, we don't want to replace the bump of the head of the talus with a bump of all this redundant collagen. And by resecting the capsule, by doing a Pulver-Taft weave to tighten the musculotendinous unit, we don't add much collagen, we actually take some away. The foot is not a joint. There's valgus eversion of the hindfoot, supination of the forefoot. In the upper left, you can see before the calcaneal lengthening osteotomy, there's valgus of the hindfoot. All the metatarsals are on the ground because there's supination of the forefoot in relationship to the hindfoot. And in B, after the calcaneal lengthening osteotomy has corrected the valgus deformity of the hindfoot, in this case, we can see it's uncovered the supination of the forefoot. The angle between the metatarsals and the calcaneus is no different before or after the calcaneal lengthening osteotomy. The calcaneal lengthening osteotomy, as you see in C, after the calcaneal lengthening osteotomy has already been performed and secured with a wire, corrected the hindfoot, it's uncovered the forefoot supination. If we go home here, don't do anything else. Again, Evans didn't say anything about this. The individual would try to walk on their fifth metatarsal head and on the center of a neutral aligned calcaneus. Can't happen. There's no way the foot is not going to try to bring the first metatarsal to the ground. That will force the hindfoot back into eversion, and the calcaneal lengthening osteotomy would be considered a failure. It's not a failure of the calcaneal lengthening osteotomy. That would be a failure of the surgeon not to recommend or not to recognize that there's another deformity that needs to be corrected. And again, the calcaneal lengthening osteotomy didn't create this, it uncovered it. So just accept it. It's another deformity. It has to be corrected. First, it has to be identified by the surgeon, and that's why you do all your preparation to anticipate that you very likely will need to do this. In some feet, especially 8, 9, 10-year-olds, the supination deformity of the forefoot, which is present, somehow spontaneously corrects after the hindfoot is corrected. But in the older child, the stiffer foot, you uncover the supination deformity that's always been there within the CPU. It needs to be corrected. So you can perform a medial cuneiform osteotomy. You do it as a closing wedge, removing bone, the base plantar, or an opening wedge. And we talked about how you make that decision. I won't go into that right now. But you need to pronate the supinated forefoot. Here you can see the wedge coming out. Foot is pronated. The osteotomy surfaces are brought together. And here I just make a wire out of a 2mm smooth diamond pin. You could spend thousands of dollars on the pre-made ones from the company, or you can make it out of a wire. It just needs to hold the bone surfaces in apposition. And now we can see in the lower left, the calcaneal lengthening osteotomy is corrected the hindfoot. The medial cuneiform plantar flexion osteotomy has corrected the forefoot. And now we have full deformity correction of the forefoot and the hindfoot. 2 deformities within the flat foot. And we can't forget that the reason the child's in the operating room is because they had pain. And the pain generator was either the tight gastrocnemius or the entire tendo Achilles. based on the silver scale test that you perform preoperatively to give you an idea about what's tight, and then confirmed intraoperatively while you're performing your hindfoot deformity correction. You lengthen either the gastrocnemius, if that's the only contracted muscle, or the entire tendon Achilles, if it's the entire contracted triceps suri, to get the third deformity corrected. And here you can see a severe flat foot deformity, calcaneal lengthening, heel cord lengthening, medial cuneiform plantar flexion osteotomy. And another example of perhaps somewhat less severe flat foot deformity, but still symptomatic because of the tight tendon Achilles, calcaneal lengthening osteotomy. The graft here is almost entirely incorporated now, several months later. Medial cuneiform osteotomy to correct the forefoot supination deformity, and the tendon Achilles was lengthened. So what are the keys to success? The key is to do all the procedures. It was 20 years between the fantastic concept of correcting painful flat feet in children and the worldwide acceptance of the concept based on a technique developed by a curious, inquisitive young pediatric orthopedic surgeon who said, I have to figure out why this great concept isn't working, and developed a procedure that is used universally. The only way that it's going to be successful is to follow all the steps. Don't be creative. It's written so many places now, you can find it. It all matters. And don't be creative until you've mastered the technique as described. I would say at this point that when I think about the procedure, my procedure for correcting flat foot deformity, symptomatic flat foot deformity based on Evans' concept, it reminds me of the Ponseti technique, the non-operative treatment of clubfoot. The only way the Ponseti method works is if you do exactly what he said. Start with supinating the forefoot, go to abducting the midfoot, then progress to everting the hindfoot, and finally dorsiflex the ankle. If you don't do it exactly as he described, it will not work. So that's a non-operative method, but success is based on following it exactly the way that Dr. Ponseti described it. And in flat foot deformity correction, I would have to say the only way it's going to work, and if you have consistent success in relieving pain, improving function, in having a lasting correction, is by following all the steps. It's not that they're individually hard. Nothing's really can only be done by one person in the world. Anybody can do all the procedures. You just have to do them in the right order, as recommended. And as I said, don't be creative. If you want to improve upon my method, then do it scientifically, and then prove that some part of it is better the way you do it, but don't just randomly do it. Follow it step by step. It'll take you no longer than 2 hours, even in a complex foot, and you'll have the success that the child needs, the family needs, and that you want to provide them. So thank you very much for your attention. I'd like to do just one more thing at this point and show you a short video. It's a 7-minute video on how to do the procedure. Let me close this and go to here. So I'm going to show this short video. It's 7 minutes.
Flat feet are normal, but flat feet with tight heel cords often cause pain.
Can you hear the
pain
video?
cannot be relieved
No,
on
we are not able to see the
Mhm.
video.
I'm sorry?
We are not able to see the video. Your presentation is seen.
Okay, let me go back then. I'm a little technically challenged here. Hold on.
So stop sharing first. Stop, then share the video.
Okay,
Yeah, perfect.
okay. And get rid of this one. Go to And I assume you can see it now?
Yes, yeah.
Okay.
Flat feet are normal, but flat feet with tight heel cords often cause pain. And if the pain cannot be relieved non-operatively, surgery is indicated. One can start medially or laterally. Through the medial incision, expose the tibialis posterior and release it from its tendon sheath. The tendon is cut in a Z fashion, releasing the dorsal 1/3 from the navicular. That will leave a plantar stump that's 2/3 the original thickness of the tendon and will act as an excellent anchor for the pulpit taft plication weave. With eversion, the plantar medial aspect of the tailnavicular joint is redundant and elongated. Resect a wedge of thick capsular tissue on the plantar medial edge. After the calcaneal lengthening, osteotomy inverts the subtalar joint. The distal and proximal edges can be brought together side to side rather than overlapping and creating excessive collagen. On the lateral side, incisions made through a Langer's line over the sinus tarsi, protecting the superficial perineal and sural nerves. The peroneus brevis is identified as such, and below it, the peroneus longus released from its tendon sheath is confirmed to be the peroneus longus, the pronator of the supinated forefoot. It will not be lengthened. The peroneus brevis, however, must be lengthened because it would otherwise resist distraction of the calcaneal fragments. Elevate all soft tissues from the dorsum of the calcaneus from the critical angle of Gissane distally. Then insert a Fourier elevator perpendicular with the side of the foot. It will encounter the middle facet. Rotate distal medially until it falls in the interval between the anterior and middle facets, the site of exit of the osteotomy. Replace the thin Fourier with a broader Joker elevator, exactly right in an interval, confirmed with mini fluoroscopy. The aponeurosis of the abductor digiti minimi must be released from the calcaneus and also cut transversely because it will otherwise tend to prevent distraction of the calcaneal fragments. A narrow Crago retractor is placed deep to the isthmus of the calcaneus extraperiosteally, and the Joker elevator is reinserted over the dorsum of the calcaneus to that interval between the anterior and middle facets. These two retractors will now show the exposure of the eventual osteotomy. They'll also be in place to protect the soft tissues during the osteotomy. This child had contracture of the entire triceps surae, so an entire Achilles tendon lengthening is indicated. Through the anteromedial approach, the sheath is opened and the plantaris tendon divided. I like to make an oblique sagittal plane cut rather than a box cut Z lengthening by tapering distal laterally and proximal medially. There'll be thin ends to create a very cosmetic repair without bulky ends under the skin afterwards. A wire is inserted from the critical angle of Gissane to the posterior edge of the interval between the anterior and middle facets, and this is the guide wire for the sagittal saw that creates the osteotomy with the retractors in place. It's a complete osteotomy through the medial cortex. A lamina spreader is inserted and opened to invert the everted subtalar joint and closed to evert the inverted subtalar joint. This is exactly what the osteotomy is going to create. Hold the foot in the fully everted position and insert a 2 mm smooth Steinmann pin retrograde, passing across the very center of the calcaneal cuboid joint and stopping at the osteotomy. Spend a couple of minutes here to confirm that you have not pre-subluxated the joint. Then the laminar spreader in place will determine how large the graft will be laterally. This is a trapezoid and not a triangle. Choice 6 will be placed in the anterior and posterior fragments and the graft inserted and impacted. Align the cortical surfaces of the graft with those of the anterior and posterior calcaneal fragments. It is inherently stable. We can see by fluoroscopy there's perfect alignment at the tailnavicular joint. This foot has some forefoot adduction as well as the clinical supination. We see no subluxation at the calcaneal cuboid joint, and the graft is in perfect position. The wire is inserted retrograde through the graft and into the posterior calcaneal fragment. Again, this foot had not only supination of the forefoot, but also adduction. So a dorsal medial opening wedge osteotomy is performed to correct simultaneously both deformities. A wedge is placed with the base dorsal medially. It's impacted. And because of the dorsal medial position of the base, there's concurrent correction of supination and adduction. No fixation is required. We can now see a beautiful arch. The transverse plane of the metatarsals is perpendicular with the tibia. Fluoroscopy confirms maintenance of alignment at the tailnavicular joint. The adduction has been corrected, and clinically the supination has been corrected, and we again confirm no subluxation at the calcaneal cuboid joint. The redundant capsule has already been resected, so the capsule is repaired from anterior to posterior with figure of 8 sutures of 2-0 or 0 vicryl, plantar medially only, and there's no need to use permanent sutures. Non-absorbable sutures work perfectly fine. 8 weeks of casting, and this capsule will be repaired. So we don't need to leave any permanent sutures in place. The tibialis posterior will now be plicated with a pulver-taft weave, a slit made in the distal stump, and the sutures from the proximal slip pulled through. This is usually a 7 millimeter distalization of the proximal piece, plication, and it's repaired with 2-0 or 0 vicryl sutures. Had this been plicated with side-to-side tendon with a simple transverse cut, it'd be much bulkier collagen, and this is very smooth, thin, and we're not replacing the bump of the head of the talus with a bump of redundant collagen. Extend the knee fully and dorsiflex the ankle 10 degrees. Then repair the tendon of Achilles with a running suture of 2-0 vicryl along one edge and then up the other edge. These tapered cuts make a much better repair. You can't feel the bulky ends under the skin afterwards. See, all the deformities are corrected, and there's 10 degrees of ankle dorsiflexion with knee extended. Then simply repair without tension the peroneus brevis ends side to side with 2-0 vicryl sutures. Child will be in a non-weight bearing cast for 8 weeks with cast change at 6 weeks, simulated standing AP and lateral x-rays at both 6 and 8 weeks, and removal of the wire at the 6-week point. After 8 weeks, physical therapy will be initiated. Thank you.
Yes. So can we have few questions? Hello.
Can you clarify about the medial cuneiform osteotomy? Is it a closing bench or an opening bench?
So for the medial cuneiform, I performed a study, a cadaver study a few years ago, and I confirmed what I'd seen clinically for decades, which is that to plantar flex the first ray, one can either remove a wedge from the bottom of the bone or put a wedge of bone in from the dorsum. So medial cuneiform, if you have a supinated forefoot, you want to plantar flex the first ray, you can either take a wedge out from the bottom or put a wedge in from the top. But because of the local anatomy of the medial cuneiform, there's always a secondary transverse plane effect. There is no constraints medially on the medial cuneiform. On the lateral side of the medial cuneiform are bones and joints, ligaments. So if you take a wedge of bone out of the bottom of the medial cuneiform, it will slightly adduct the forefoot because of the lateral tethers. If you put bone in from the top, it will open more, it will plantar flex, but it will open more medially than laterally, so it will slightly abduct. And that means if you have a typical flat foot that has no deformity between the midfoot and the forefoot, it's only the E version, straight between the midfoot and the forefoot, I would take the bone out from the bottom because it will plantar flex the first ray, correct the supination, also slightly adduct the forefoot. You're trying to bring the forefoot in. But if you have a skew foot where there's already adduction of the midfoot forefoot, if you take bone out from the bottom, you'll exaggerate, you'll add some adduction to the forefoot that you don't need. So if there's some adduction of the midfoot, put the bone in from the top, it will plantar flex the first ray, correct the supination. It will also simultaneously correct some of the forefoot adduction in the skew foot. Okay, so you have to look at that point. If you don't see any deformity from the midfoot to the forefoot, you correct supination by removing bone from the bottom. If you have adduction between the midfoot and the forefoot, as well as supination, put the bone in from the top, as I did in that video.
Yeah, Thomas.
Vince, can I ask a question?
Sure.
This is for CP in spastic diplegia. They recommend a subtalar arthrodesis for the older children with GMFCS 4 and 5. Do you recommend that, or is a calcaneal lengthening osteotomy enough?
So, when I was starting out, I saw the power of the calcaneal lengthening osteotomy, and I recommended it for everybody. And what I saw was that in children with GMFCS 1 and 2, it works great. That operation I described in slides, showed in the video, it works fantastic. In GMFCS 3s, no matter how good you are at SIMLs, at single event multi-level surgery, they're still going to pound their feet. They're still going to try to go into crouch. They're going to be so hard on the reconstruction that it doesn't succeed very well. It looks great on the table, but once they've had an opportunity to pound their feet and their legs, it fails. So in most GMFCS level 3s, and definitely 4s and 5s, it's more appropriate to eliminate subtalar motion because in the 3s, you want to have a rigid lever arm. And in the 4s and 5s, you just want a comfortable foot that doesn't lead to creation of sores and pressure areas on the feet. So triple arthrodesis is extremely difficult in valgus in flat foot deformities. It's very easy in cable varus deformities, just technically, but it's very challenging in a flat foot. And what I've found is that the talonavicular joint fusion is an easy triple. The talonavicular joint is the anterior end of the subtalar joint complex. And if the talonavicular joint doesn't move, the subtalar joint doesn't move. So one can perform in the GMFCS level 3s and definitely 4s and 5s an isolated talonavicular joint fusion. Don't go through all the process of trying to remove the subtalar joint. When you have a solid talonavicular joint fusion, the subtalar joint is fused, so I call it the easy triple. In some cases, especially in the 4s and 5s, excuse me, while you're performing the talonavicular fusion, you sometimes see some opening of the calcaneal cuboid joint because they're so severe, they're so deformed. So resect the talonavicular joint, articular cartilage, bring it into apposition, and if the calcaneal cuboid joint moves in along with the subtalar joint, fine. If it doesn't, and you have temporary fixation across the talonavicular joint in preparation for the screws, stop there, remove the cartilage surfaces from the distracted calcaneal cuboid joint, and just fit a graft in and put a screw across that. So you never have to get to the subtalar joint. Talonavicular joint fusion alone is generally adequate, except for the really severe foot deformities in the 4s and 5s. If you need to, temporarily stabilize your TN joint, resect the cartilage of the distracted CC, put a bone graft in, put screws in both, and you're done.
Yeah,
Thanks.
Thomas, please. Yeah.
No, and then your video, you also showed that you start with the medial incision. Most of us actually start with the calcaneal lengthening, look at whether the arch is formed on the medial side, and then proceed with the medial side. But in your video, you started the other way around.
So one of the principles of complex foot deformity reconstruction is expose everything, prepare everything before you complete anything, then do deformity correction, stabilization, and finally do tendon transfers. So exposing one side or the other is immaterial as long as you accept that part of the flat foot reconstruction is plicating the medial soft tissues. So I could have started laterally and then said, okay, now I'm going to go to the medial side because I wasn't going to complete anything. I didn't complete anything until I exposed everything.
I have a question. You talked about the supination deformity of the forefoot. So let's assume that the supination deformity is like this. This is being the medial side, and this is the lateral side. So now
Yes.
the foot is like this.
Yes.
Now, when we carry out a osteotomy of the first ray, we are bringing it down like this.
Not quite. If
No,
you
the
perform
but the question is, the second, third, fourth,
Yes.
they are still tilted like this. So we are touching the tripod. So we are making the tripod touch, but still the second, third, fourth ray are in an oblique plane. They are in a supinated position.
They are, but by performing the osteotomy in the medial cuneiform, there at least seems to be, I haven't studied it with like pre and post-op CT scans, but there appears to be some effect of also rotating down the rest of the forefoot by doing the medial cuneiform. If you're performing the osteotomy through the first metatarsal, which is certainly what most people do to correct pronation in a cable varus foot, if you perform an osteotomy of the base of the first metatarsal, the rest of the metatarsals, the midfoot, has no reason to do anything else but stay where it was, because the first metatarsal is so separated, except by a few ligaments, from the second and the cuneiforms. By performing it through the medial cuneiform, you actually keep everything together and it moves more as a unit. In the severe, very, very severe feet, like in the maybe GMFCS 4s and 5s, if you cut through the medial cuneiform and it doesn't come down far enough, you could continue your osteotomy through the other cuneiforms. You could go back a little bit and bring them down. So yes, there are some constraints to them all. I consider it like moving like a fan rather than isolating the first ray. There's much more opportunity for the local ligaments to enable the rest of the midfoot to come down with the medial cuneiform osteotomy than in the first metatarsal.
And then the question is like, we do this procedure a lot in cerebral palsy. So how the surgery which you described for mainly the flat foot, how when we do it for the cerebral palsy, is there a technical difference or more or less it's the same thing?
When Evans reported his concept, his operation in 1975, he specifically said, do not do this procedure in children with cerebral palsy because their muscle imbalance will create recurrences, and do not do it in children with myelomeniingocele because their bone quality is so poor it won't work. My original series was all kids with cerebral palsy and myelomeniingocele. And because in 1983, when Phillips from Cardiff, Wales, reported a 13-year follow-up, they said, and even though Dillman Evans said, don't do it in these patients with these underlying conditions, it works. So that sort of gave me permission to try it. And that's who I was seeing at the time. So in the beginning of my series, most of the kids I was operating on had CP and myelomeniingocele. And then the last several decades, it was mostly idiopathic flexible flat foot with tight tendon Achilles. So the muscle imbalance in children with cerebral palsy will make anything you do tend to fail, because the problem is not the foot, the problem is the neuromuscular system. What that brought me to conclude was what I said: for the 3s, 4s, and 5s, fuse the talonavicular joint. For all of them, particularly the 1s and 2s, if you have any inclination that the forefoot supination is anything other than perfect, correct it. Don't assume it's going to get better. For the idiopathic, you say, I'm not sure, idiopathic flat foot with tight tendon Achilles, maybe I'll do the medial cuneiform. If the child has CP, always plantar flex the forefoot, because the plantar flex forefoot, pronation of the forefoot, is going to help drive the hindfoot into varus. And,
Right.
and one other thing that some people have done in CP is to transfer the peroneus brevis to the peroneus longus. So instead of just lengthening the peroneus brevis, which is important, actually transfer it to the peroneus longus. It's the reverse of what we do for cable varus foot, where we put the longus into the brevis. So transfer the brevis into the longus, and that will be another way to decrease the spastic eversion of the hind foot and add some more pronation force to the forefoot.
Okay, and then the last question is like, in the video, I saw that there was only one K-wire in the calcaneocuboid. So is it always like that, or you use 2 K-wires?
There's been a lot of discussion in some articles recently about subluxation at the calcaneocuboid joint. And in most cases, it's a no-brainer. They didn't pin the joint. Of course, it's going to subluxate. It said that 35 years ago. But some people have said, I pinned the joint and it's still subluxated. And my response to that is, then you didn't pin it. It's solid body geometry or biomechanics that if you have two solid objects and you put a pin through them, 2 blocks of wood, they're not going to subluxate. They might rotate. And I think that what looks like subluxation in pinned joints that are pinned appropriately, it may be rotation. If you put your pin in, you distract the bone, and it looks like it's subluxating, take the bone out, make the foot flat again, reinsert it more centrally. If it still seems to subluxate, add another wire. And so you have 2. And it's not a sign of weakness or failure to put 2 wires in. It's a sign of weakness and failure if you don't prevent subluxation. So 2 is fine. I even described that in 1995. People don't read that sentence, but I wrote back then, if that happens, do it. So 1, but if you need it, 2, always put in the wire or wires with the graft out of the foot and the foot in the flat position so you don't pre-subluxate it.
Fine. So thank you very much. I am sure that the technical details which you explained, if we look at this video whenever we are going to perform this surgery before the day, then I'm sure that we will get a wonderful result, wonderful correction, and we will be having a stable foot. I'm sure we have read your chapter in the textbook, but still your own description about each minor details is going to help us a lot. So thank you very much for sharing your experience on this procedure with us. And
thank you.
Yeah, see you soon again with a new topic. Thank you.
Thanks. Bye.
Thank you. Bye.
All right, thanks again.